just want to welcome everyone to tonight's IG Live, which is focusing on women's health. I'm in honor of National Women's Health Week, which is this week. I'm Melissa Schenkman, and I'm the founder of YMyHealth, which is a health resource that is for and by millennials. At YMyHealth, we focus on taking complex healthcare and breaking it down, always with millennials in mind. We cover topics ranging from heart health to mental health, nutrition and fitness, to millennials and cancer, and so much more, as you will see tonight. You can check us out at YMyHealth.com and at YMyHealth here on Instagram and on Twitter. We also have a monthly newsletter that you can subscribe to for free. It just came out today for the month of May, actually. And you can get early access to new content there. I am so excited to have Dr. Jessica Gray here with us tonight. She is an award-winning, board-certified family medicine physician in Lubbock, Texas, who cares deeply about women's health, as I do. And as a fellow millennial and woman who has talked with my family and my friends around the country, there always are so many questions about how to navigate healthcare for women. I think, and sometimes more questions than answers, because there are just so many things that, as you know, that we deal with over time. And so I think it's really important that we are able to dedicate this time to talking about some things that really matter to women, and in particular, of the many things we'll discuss, would be really kind of what are some things to have on our radar during the different decades of our life, because just millennials alone combine really different decades at this point in our health. And then also how to be our own advocate and our best advocate, really, when it comes to women's health. So welcome, Dr. Gray.
Thank you so much. I appreciate it. I'm happy to talk with you. And as you said, women's health is definitely something that we focus on in my practice. In my practice, it's me, and I have 3 advanced practice providers, 2 nurse practitioners, and a PA. And that's just one of the things that we love focusing on. Of course, we see everybody in all ages, but definitely women's health is a big deal to us.
Oh, it's wonderful. And that's why we are just so excited to talk with you about these things this evening. And just wanted to let everyone know before we get started that we're not going to be addressing any specific individual health concerns, that if you do have those, we always encourage you to talk with your own healthcare team. But if you do have questions that come up about our discussion tonight, we would love for you to put them in the chat. We'll get to as many of them as we can at the end. And to get started, I really wanted to kind of start with, as you decided to go into family medicine, you've always had women's health be something that's resonated with you and be, like you said, a huge part of your practice. And I was wondering if you could share with us a little bit about why that area of medicine was something that has always really resonated with you.
Yeah, absolutely. So I think one of the questions that we get a lot, especially when we're interviewing for like and things, they ask you, why are you interested in a specific field? Or when we're in med school, they ask you, what do you want to go into? So I definitely wanted to go into primary care and family medicine. Number one, I like family medicine because I like everything. Mm-hmm. I like treating all age groups. I like being able to have that continuity of care with a patient where you see them year after year, you watch them grow, you actually see them there. And it's really validating to you as a physician as well, because you know that you're kind of holding their hand, working with them step by step to try to help them take control of their own health, which I really find I get enjoyed for me personally too, doing that too. And then, I definitely remember wanting to do things like OBGYN, and I loved all the GYN aspects of it. I didn't like hours, and I'm not a big fan of the OR. Everything with the blue, we were not allowed to touch, it always felt like you can't touch. So that was always a little overwhelming. But, and then I love the mental health aspect. I love psychiatry. In fact, I considered going into psychiatry as well. And so family medicine was a great place where I could do both women's health, psychiatry aspect, and then still get a lot of different variation in my day. I get to take care of things like diabetes and high blood pressure, and then really see how those specific things affect women. And they do affect women and men differently sometimes. And that is something that we have to think about and be sensitive to, just on maybe their roles in their family or other aspects that they may have to think about at the same time, besides just, what is my hemoglobin A1C running? Mm-hmm. So it's that being in family practice has really allowed me to grow my practice in a way that I like to, every couple of years we can kind of, shift or think about what we want to do more or less of, which is really nice as well. And so it's really just grown to have more and more women in our practice who feel comfortable seeking out questions, or maybe they have gone other places and asked questions and didn't feel validated. Or so we try to be a place where we can ask all questions and feel inclusive of everyone.
No, that's wonderful. And to your point about how different conditions can affect men and women differently that you were mentioning, what would you say are some of the common perceptions about women's health by the public, and how can we change some of those, do you think?
Yeah. So I think one of the interesting things that I wasn't exactly prepared for when I came into practice was that I have a lot of women that come to me and they come in and they say, I know something is wrong with me. I just feel it. There's something. I've been to 4 different doctors already. I've been to a naturalist. I've been to this and that. And, they just tell me it must be my hormones. My hormones are wrong. Mm-hmm. So when they come in and they're like, I need you to run labs for all my hormones. Well, but then I try to go into explaining that, we have a lot of hormones in our body that do a lot of things. We don't even have labs to check on some of these hormone levels. And so it really is one of those things that somebody's told them over and over again that their ache or pain or their fatigue or something just must be hormone related. And some people even stuck them on hormone replacement therapies at young ages inappropriately without telling them the risks of what could happen. And so one of the interesting things is that we really try to delve a lot deeper and even look at that mental health aspect of it. And not all the time, but a lot of times there are some underlying things that are not hormonally related. They may be more related to a mental health approach, maybe some anxiety, some depression, some OCD behaviors. Sometimes there's a underlying eating disorder that we try to work out as well. Sometimes it's completely different and it's not hormonal like your estrogen and progesterone, but we're looking at something like insulin resistance or, a pre-diabetic state. And so really trying to help them understand that, maybe they've been blown off before or just told it's all your hormones so many times. We want to look at for a much bigger picture and not just label things as, well, you're a woman. And so if you've got complaints about fatigue, it's probably your hormones.
Oh, absolutely. And that's definitely a common thing, and great thing to point out, which will lead into, as we go more into talking about being your own advocate, that is one of the areas definitely to think about. And to that point, how do you think kind of we can change that perception about it being hormone related, and people having that thought?
I think we've got to be careful a little bit about with social media, especially. I know we're on it right now. We're talking about things. So if social media, especially in the age of TikTok, which honestly was out, it was just as bad with Dr. Google and Instagram and all that too. But in the age of social media and everything being just so readily available at your fingertips, you can literally Google or search for something that let's say that you wanted to say if you stood too long out in the sun, you will turn into a plant. Okay. You just make up something. Well, you could probably start Googling that and find someone else somewhere in this entire planet that wrote some kind of blog post about, I had a friend who stood out too long in the sun and they turned into a plant. I use that as kind of a silly example, but it's true that you can really searching for things and you'll find the answer you're looking for and not necessarily the correct answer. And so we've got to be careful because we have to change that perception by also not continuing to propagate that stigma or problem, over and over again by feeding into it, saying that, yes, it's just your hormones, or, you need to go do this or you need to do that on social media. So we do need to hear people on social media who have a background in, maybe women's health or even just primary care, OBGYN, or something else that's really reputable, because just any other person can log on, claim they're a doctor, claim they're a medical expert, and they can just start telling you about, they need to do this, or if they do this liver cleanse and their liver will be cleansed of all your toxins and then you magically be, cured of all your ailments. Because one of the things that's also hard is when you're a physician and you do know what you're talking about, it's really hard to combat medical misinformation, because patients will come to read this and it says, the liver needs these toxins and it'll clean itself and all these things. And it's just really, sometimes these thoughts are so crazy when you are in the medical field and you've been trained on it. You're like, this physiologically, that doesn't even make sense. That it have a good argument back. You can't be like, isn't real. This doesn't make sense. And so it almost backs you a little bit into a corner. And so I think if we're going to change the way everybody views these things, that we're not just jumping to these conclusions or throwing people on medications just because they ask, we really need to change the conversation about, okay, sometimes we have fatigue, we need to look at it from a much broader picture. We need to look at it from, what is the hormones. Okay, sure, we can look at it there, but we can also look from, a much bigger standpoint, again, including that mental health aspect, looking at your cardiac potential complications. There's GI complications. There's many things that we need to think about. Nobody wants to hear that you need to exercise more and eat right. I think that we're all looking for a easier way or a better solution. And unfortunately, sometimes TikTok and those things just propagate that idea of just take this pill, do this diet, go to this person who may sell you something. And we just really got to be more responsible about what information we put out there and then what information we're consuming.
Oh, I absolutely agree. And that's why we're so fortunate to partner with you and with other people who are experts in their fields, because we want to support, putting out reliable information when we do. And we're always kind of providing, journal articles and other really reliable sources within our articles to communicate accurate information. I agree with you completely. I just wanted to kind of switch gears a little bit and think about this large age span of millennials that we're in, and basically in our 20s, 30s, and 40s, and really each time, if you ask anybody, each time you enter a new decade, you experience different aches and pains, different health conditions that you have to be aware of, and preventative screenings. And especially in this age group, I feel like, because with childbearing age, there's just so many things that come up. And so I kind of wanted to talk with you about kind of what are some of those things, if you're in your 20s versus 30s versus now, believe it or not, early 40s, for millennials, that we should kind of have on our radar when we're going in to our physicians, and just know, like, these are things that I may, in this decade, that I may encounter, that I should be aware of, or I should bring up in talking.
This is actually one of my favorite questions to answer, and I get asked this a lot, especially when I do like social media questions or interviews for local media stuff, like the newspaper and the magazine stuff. They always want to ask this question, and I love it, because this is one of the areas where the medicine is different for men and women. Mm-hmm. Men has many age-related screenings as we do as women. So particularly, let's just start with your 20s. So the very first of in our 20s, we got to think about 21 years old. That is the year that we start your cervical cancer screenings. Mm-hmm. So that's going to be pap smears. One of the things I really like to emphasize with my women, especially when it's their first time getting a pap smear, is there's a difference between a pelvic exam and a pap smear. A pelvic exam is the exam we use when you put your feet up in the stirrups, so you get your uncomfortable position and everything, and you have to have someone take a look, right? But we can do that for STD screening. We can do that for abnormal bleeding. We can do that for a whole amount of reasons. The actual pap smear itself is the extra little brush that we use that swabs the cervix and takes a little bit of those cells that we put underneath the microscope. And that looks for pre-cancer or cancer that we start, and we do that at 21. You can have a pelvic exam before that. You can have one, much, much younger if we're having any issues. But some women come into me and they said, oh no, I already had a pap smear. I had that when I was, 18. And so, yes, there are people that may do pap smear guidelines slightly different. The recommendation is to start at 21. But old recommendations in the millennials' lifetimes, they're on the older side like I am. It has changed quite a few times, but right now it is 20. But they may not understand, okay, what was happening to them if it wasn't really explained clearly that, the pelvic exam and the pap smear are different things. But on that note, the pap smear is done at 21, and it's done once every 3 years, as long as it's in that normal result underneath the microscope. If it looks normal, you'll do it every 3 years until you turn 30. Once you're 30, you actually have the option to add in an additional test to it. So we can put the cells under the microscope and look at it. If those look normal, that's great. That's step one. We can also test it for the HPV, the human papillomavirus. Mm-hmm. If the human papillomavirus and the cells on the microscope are normal over the age of 30, then you don't have another pap smear for 5 years. So it buys you a couple extra years, which is really nice. And that is part of those newer guidelines that it's really important for you, whoever's doing your pap smear, to be aware of and follow those guidelines. So it buys you some extra time, but it also more accurate detecting certain cervical changes or things that would lead to cervical cancer later on. So definitely, the first thing you think of in the 20s is that 21 years old pap smear. STD screening that's both men and women, of course. For anybody in there, especially when you're in your 20s, younger ages as well, but starting in your 20s, you should be routinely asking that at every annual wellness exam, any preventative exam. I tell my patients they need to be doing it with every single partner, every new partner, or at least once a year, just to make sure that we've got that STD screening covered as well. Throughout your 20s, that's really the biggest thing is we're talking about cervical cancer screening and, STD screening. Once you get in your 30s, things are a little bit different. For both men and women, we generally start things like cardiovascular screening with cholesterol panel, and we get to talk about all the fun cholesterol stuff. It starts to make you feel like a real adult once you turn 30. So in your 30s, I like to tell my patients in their 30s, what they're doing now is for their health is setting the tone for what's going to happen in your 40s and 50s. So I feel like 20s, you can maybe fool around a little bit with a little, too much Taco Bell or McDonald's or whatever. But when you get that 30s, these decisions you're making right now, these patterns for your health, whether you're active into exercising or what you're eating or how you're staying on, this is the patterns you're creating for when you go in your 40s and 50s. So 30s, 20s pap smears, 30s really cardiovascular screening and all that stuff starts. Still continue with the pap smears, of course. And then you hit the big 40. For women, that's a little different than men. Men don't have the big 40. But 40s when we start mammograms for most women of average age, our average screening. So mammograms are going to be when we look for breast cancer. We start those at 40, depending on which guidelines you follow. And there's actually a couple different societies for what the guidelines are. You do them every 1 or every 2 years. The society that I personally follow is the same one that our cancer center locally does, which is the American College of Radiology. So those are the mammogram radiology experts, American Cancer Society's their ideas, and then also it falls a little bit with the American College of Obstetrics and Gynecology suggest. So those are the starting at 40 and going every single year. American College of Obstetrics and Gynecology says you can start at 40 or 45 every 1 or 2 years, depending on patient preference and risk factors. Personally, especially since post-COVID, I've been really big on my patients to do it at 40 and every single year and not do every 2 years. What I've found patients that were doing it every other year, especially when something crazy like a worldwide pandemic hit, they didn't go in to get one year, and so it ended up being 3 years. Or they, thought they did it last year, and then it turns out they didn't. Trying to remember to do something every other year is much harder than just knowing once a year, every June or every October is my mammogram. So I really do try to push them to say with the once a year mammograms, because let's say you did miss one, well, at least as you haven't gone 3 years past that fact. And
Absolutely.
It'll pay for it every year too, which is really helpful. And then you hit your 40, and that's for both men and colon cancer screenings. That's the colonoscopy. And that is something that has changed. It used to be 50 and now it's 45. So that's very, very important. And depending on your risk factors as well, they may actually tell you to repeat it in 1 year, 3 years, 5 years, 7 years, or 10 years. So all of these things are really tailored to you and your family history. If you have risk factors for some certain cancers or certain family members have had things, or you're having certain symptoms, then we may actually do a lot of these screenings out of order or earlier or later, not necessarily later, but usually earlier or more frequently. Definitely you need to be able to know what is the minimum expectation. The minimum would be like, a pap smear at 21. But if you're having increased risk for anything else, you need to know that how the guidelines change just based on your personal medical history.
Oh, absolutely. And along those lines, kind of, talking about kind of the top things that women should do to prevent these common conditions from happening later in life. What about osteoporosis? That's another big one. And I think that's something that is not on the radar of, well, definitely not on the radar of the 20-somethings, probably. Maybe some in the mid-30s on, but definitely on the radar of the millennials that have gone into the 40s, because we're hearing, oh, this can come, in the 50s. And actually, I know that bone loss can, begin much earlier than that, as far as bone mass, changing. So kind of what do you advise? I'd even say, starting in your 30s, women to think about in terms of that, to try and prevent them from ending up getting diagnosed with that much later on.
So I think this is one that's been interesting in the news a little bit more, and there's been some new research out there about osteoporosis and osteopenia prevention. So osteoporosis, just for anybody who, sometimes I get patients who ask this a lot, they want to know, like, oh, my joints hurt a lot. I have a lot of pain in my joints in my back. It must be osteoporosis. And so not the correct definition. So osteoporosis is a thinning of the bones. So that's when we lose bone density that makes you at higher risk for a fracture if you were to slip and fall. Osteoarthritis is when we have that wear and tear on the bones that can cause that aching and pains in joints. And so a lot of times patients, they'll hear, well, someone diagnosed me with osteopenia or osteoporosis, and they'll intermix. Those are completely separate things. So we're talking about osteoporosis, the thinning of the bone. That's actually something that we don't start screening for usually until you're 65 years old, or if it's 2 years past when you went through menopause. So most women, roughly, give or take, go through menopause in their 50s. Usually, let's just say 50 years old, you went through menopause. Then roughly 2 years later, we would start screening for somebody traditionally with for osteoporosis or osteopenia, lesser version of it. Now, there are people that are on certain medications, like chronic steroid users. Somebody who has maybe some very, very, very severe asthma and has to be on long steroids, or somebody who has some rheumatologic diseases that they have to be on these steroid medications for a long period of time. They may actually have to have it done sooner. There's also certain patient populations that I deal with, including patients with anorexia. If you've got a patient who has a history of anorexia, they actually need a bone density scan 1 year after a period of restriction, because they do have some bone density changes from that nutritional deficit. So it's really tailored to what, was going on with that person. For the average person, the average viewer for your platform, yes, they don't need to be worried about it in their 20s and 30s. And in their 40s, don't have to be really super concerned about it. Some women will come to me and say, oh, I need to add my vitamins in. Do I need to be on calcium and vitamin D? The most recent studies that have been available have actually kind of gone against a little bit our idea of put everybody on vitamin D for prevention. You talk to some of the rheumatologists locally, especially I have a good friend who's one. She definitely has talked about it's not been proven as helpful to prevent. But when screenings, and let's say you have osteopenia, which is the beginning to osteoporosis, it has been shown to help at preventing it from progressing. But other things that help prevent it from progressing or help prevention in general are things like weight-bearing exercises, and just trying to stay, not smoking, trying to stay physically fit. A big thing is that if you do have osteopenia or osteoporosis, your big risk factor is if you fell. So we talk a lot of times about making sure we're good with our balance. Sitting all day in a chair all day is not great for your balance. Trying good activities, things like yoga, Pilates, whatever they're interested in doing, but things that can get them feeling strong. And so if they did have a slip or a fall, if they felt like that avoiding the fall is probably your safest bet.
Oh, that's a great point, and very interesting on the research too. Always appreciate, bringing in everything that's cutting edge, because that is something that people are so commonly told, as you think, oh, I need to be really good about taking my calcium and my vitamin D.
So women about, but usually that's going to be your women, again, in your 50s, and we're talking about your perimenopausal, postmenopausal women with doing that. I don't routinely advise a 40-year-old or 30-year-old to be on calcium or vitamin D specifically for prevention for bone density loss. Definitely vitamin D, though, there's a lot of people that don't get enough of it in their diet.
True.
It's a limited amount of sun exposure. You truly need to get your vitamin D. A lot of people as well. And so vitamin D deficiency is really common. Yes. And so if you have vitamin D deficiency, yes, you need to be treated, you need to be monitored, and you need to be taking your vitamin D supplement according to what your doctor prescribes it for, which ranges in the actual dosage for it.
Sure. No, absolutely. So given all of this, I think, there's so much to think about in terms of our health when it comes to different conditions, different preventative screenings to think about. And also there, like you had mentioned, as you get further along in your 30s and even beginning in your 40s, you think about things like heart health, because ultimately everything is connected when you think about it. And sometimes, especially with women, you can have symptoms that are very different, obviously, than men, but that come from one area. You feel it in one area, but it's coming from a different area. So it's all really connected. And so just kind of in thinking about that, with all that we have to keep on our radar, what are some steps that we can take to being our own advocates when it comes to women's health? Both, I think even ahead of going to our appointments as part of that too. And then while we're there, that would be really great to hear kind of your thoughts on that.
So I think the number one piece of advice I could give a patient before they come to their appointment is know their own medical history. So know the last time you had a pap smear. And again, remember the difference between a pelvic exam and a pap smear. Know the last smear. Know what the result was. Be able to tell your doctor, okay, I had this done on this date. Know about your mammogram, when your last one was, have some of that information. Know that if you were ever diagnosed with a certain condition in the past, I have patients often come into me and we'll start a conversation for like a new patient visit, and they'll say, I'll ask them, okay, about their past medical history. Have they ever been diagnosed with any medical problems, ever been hospitalized? And they say, nope, never been hospitalized, don't have any medical, nothing. I'm like, oh, okay. Well, I use the medication list as my little cheat sheet usually. And so I look on this, okay, well, you're on levothyroxine, which I assume is for your hypothyroidism.
Mm-hmm.
Okay, and then you're, on lisinopril for your blood pressure. Oh yeah, I have blood pressure, but it's fine when I take my medicine. And then I see we're on metformin, and for also, do we have a history of diabetes or PCOS? And so pretty soon I'm using the med list to kind of steer the conversation. So it does help when I say, oh yes, okay, well, I was diagnosed with diabetes in 2006. I've been on this medicine. I've tried these other medicines and they didn't work, or I had these negative side effects. And, you don't necessarily have to blurt it all out like that to the doctor, but coming in, being able to answer those really good questions about, have I had to have a breast biopsy before? Have I had to have a be able to answer those when the doctor asks those questions, or bring your medication list, bring the bottles with your medicines. If you're not sure and don't have a really well written list, just bring the bottles with you. We can figure it out. But sometimes patients will say, well, I take this yellow pill and I take it, once a day. Don't you know the yellow pill for the blood pressure? And so manufacturers make them in all sorts of different colors. And so we don't know it just based on the yellow pill. So knowing your history, knowing what medicines you're on is really helpful before you come in, just so that we can help you too. And then just kind of being prepared for what's going to come. I talk to my patients, like when you're 38, I will tell you every year you see me until you turn 40 that we start mammograms at 40, just to get you mentally prepared. Mammograms coming once you turn 40, every single year I will prep you saying you will have a colonoscopy at 45, just get you mentally prepped there. Mm-hmm. And so to your doctor, and I think that's a good advice to kind of ask, maybe when you do turn 40, you're just like, hey, in the next 5 to 10 years, are there any new supposed to have, maybe I'm not getting them now, but I just want to keep it on my radar so I'm mentally prepared. I think compliance for those screenings is a lot better. People actually go follow through with them if I've mentally prepped them for a couple of years before it's coming.
That's a great idea. Absolutely. And actually on that note, in terms of the screenings, I think one thing that women deal with more than men more commonly is having to know, when should I push, for further screening maybe, and I think women deal with it more, and then you combine that with the aspect that we're younger, and that can sometimes be a difficult mix, let's put it that way, to get the screening, insurance coverage aside. But one of my friends had talked to me about, how that they kind of had dense breast tissue, which is common with women, and that they didn't know that they really had to kind of push to get, the ultrasound or the MRI, as opposed to just a standard mammogram or even the 3D mammogram. And so kind of when would you advise people, whether within that context or in others, when's it time to push a little bit further when it comes to screenings?
Obviously, we want to make sure that we don't ever tell someone to be scared to ask the questions they need to ask, right? Mm-hmm. Is that we, as physicians, if you're practicing good medicine the way you should be practicing evidence-based medicine that comes with screening guidelines. I didn't make these guidelines up. Much smarter than all day long in big conferences, and they all got together and they've done a lot of data and literature search and talks to all the experts in the field, came together to come up with these guidelines. Now, not everything is hard and fast. Let's a 28-year-old woman who comes in with a breast lump and she's concerned about it, and we go ahead and we do a breast exam in clinic. That it probably feels very benign, and statistics tell us it's probably benign, but look at based on family family history. Let's say her mom had breast cancer at 45 and she's got another family member. I would have no problem changing that screening, necessarily a screening anymore. Now we're kind of looking for more of a diagnostic purpose, and we tailor the screening they need. Like in your example, somebody with dense breast tissue, yes, we're doing an ultrasound, especially if there's a palpable mass or something we're concerned about, with a mammogram. And so it also depends on what your facility does. Our facility here does the 3D tomography, pretty standard. Excuse me, not tomography, the tomosynthesis, pretty standard. And so it's very different. Those who need breast MRIs, it goes based on genetic risk factors, personal or family history. And so if there's a concern, talk with your doctor, ask for what the guidelines they're using are, because they shouldn't be up. And if you don't agree with it, then it's good to ask, and you can actually look at those guidelines together and then see what you can do. We obviously don't want to tell patients like, okay, be Dr. Google and tell that your doctor's wrong. And it's okay to get a second opinion if it was really necessary, but be open to looking at what screening guidelines they're looking at and what questions you have and try to answer. And the biggest thing that we can do as physicians is really try to explain it in a way that they would understand and relate to. I can't sit here talking about the tomosynthesis and, the MRIs and the kind of contrast that they use for some other, coronary artery screenings and all these things, in some far off way. I need to make it so that's something that they understand in relatable terminology. And so making sure it's a conversation that goes both ways is going to be essential.
Oh, absolutely. And I think that's also, when it comes to anything, far as getting people to get their screenings, to go and with routine appointments and to really have healthy habits, is to be able to empower them, but for them to understand in order to empower them. So excellent point. Well, I was going to say, I want to leave some time for questions. And I know that there are a few that I had come in earlier. So, I know our viewers have found this conversation very informative and engaging and really timely, given that this is National Women's Health Week. And so I'm just going to check the chat and then also bring in these couple questions that I had also seen earlier. So let me just see. So I don't see any in the chat yet, so I'm going to ask you these that were burning questions that had come in. You say earlier, one is on the topic of protein, which is something, yes, is a hot topic. And so the question was, are the number of grams of protein a woman should consume in a day, are they based on her age, her weight, or the number of active physical exercise in terms of like how many hours of being really active, or is it a combination of all three? Or maybe we're missing something here in this as well.
So you're right. It's an interesting thing. When I in my clinic, I usually see things come in waves. Like patients will come in and I don't know, there's like a trend for something on the internet or TV or something that people come in asking. And so lately it has been, everyone's like, oh, my protein intake. I've got to make sure my protein intake's where it needs to be. So it's been very interesting because there isn't some number I could just give somebody and say, you need X grams of protein. We really have to look at the whole picture for them. For me personally, I'm a vegetarian. I've been one for 20 years. And so I'm not somebody who I can say, okay, I need X number of, lean proteins from meat-based products here. It doesn't really work like that. And then I come in with my patients who a lot of times they're looking at this and it's in a picture of they're trying to lose weight a lot of times. And depending on what their overall health looks like, we may actually tailor a weight loss strategies and a diet to be more inclusive of things beyond protein. So for somebody who has some insulin resistance or is pre-diabetic, we're not going to be focused as much about protein and giving you a number on that, as we are going to be looking at carbohydrates and your, actual just plain sugar balance compared to everything else you're eating. When I have a patient come in and we talk about their diet, especially with insulin resistance, which is much more of it's a much bigger issue these days that we need to look at. I'll talk to them a lot about the three-pronged approach. We can look at medications, we can look at exercise, and we can also look at the diet. The first thing I always talk about is the sugar intake, the common things we think about for insulin resistance, like candy, sodas. So this is the big one. Cookies, cake, all that sugary stuff. And then we look at the carbohydrates. And that one's usually the bigger problem because they're carbohydrate to protein, they're carbohydrates to just straight vegetables and fruits intake, nice fish, things like that are way off balance. And yes, we all remember our pyramid or little triangle thing that has the carbs at the bottom. We have become a society where this carbs at the bottom is way too big. Our triangle is much too flat. We've got to work on it again. And so we need to be cutting down on that ratio a lot more. And so some people, you know, with their protein intake, they really do, when we talk about cutting down carbs, they say, well, great, I love, you know, I like chicken, turkey, I like lean meats, I like to do, you know, cheese has protein in it. And so we have more of a overall ratio. I don't ever give someone a number of grams that they've got to work in. Okay. Now, a true diabetic, though, we may actually give them some grams to work in for carbohydrates. Somebody who's on insulin that has to match the number of grams of carbohydrates they're getting, insulin they're using, that's a completely different situation. Sitting down and talking with a dietitian, they could probably look at what you're doing and then give you maybe a little more of an estimate if you're just someone that has got to have like a grams number. Most people don't need grams though. Most people need something like, let's talk about what fits in the palm of our hand for like serving size. That's a lot easier way to look at it, because unless you're taking pictures of every single label, a nutrition label, and stop, which may be great if you're trying at the beginning. I recommend to patients all the time to use like the MyFitnessPal app. I'm not sponsored by them or anything. I recommend that people use that because you can really take an approach where you can see what you're doing in a day. I'll tell patients, just use the app for 1 week and log everything you've eaten. Do not try to diet, just log it. And that includes everything from your drinks that you're drinking, that Starbucks coffee you got, that glass of wine, everything needs to be logged in it. And then at the end of the week, go back and just look at it retrospectively and see where things were off, where you hit over a high mark, where you looked at the average amount of protein or carbs or something, just went kind of crazy with it. So use it as a retrospective look, and that helps a little bit better than saying you should only have X number of grams of protein a day. Restrictive, and people end up coming back and telling me that they're eating all this bacon and things, and I'm like, well, cholesterol.
Defeats the whole purpose.
Whole purpose. I think that we're just putting too much emphasis on one number. So don't put an emphasis on looking for as much variety. I tell patients to go to the grocery store and walk around the grocery store and get the least amount of packaged things, the least amount of things with the nutrition on them. Try to get the most color. If you can find more color in your grocery cart, the better. So everything that has a packaging label on it is probably not truly what we need to be putting in our body. We need to put the least amount of those things. So go look for other things, veggies, fruits, you know, things from the deli, things that you can really just take home that have to be, you know, things that are perishable, unfortunately, and that does make it a little harder. Okay, for sure.
No, that's a great way to think about your diet, and when you're going in to buy items, you know, for the week, as you're planning for the week, it's a great idea. One other question that had come in has to do with fertility. And, you know, this is something that is obviously really big in the millennial community. You know, if you know you want to have a family and you are single, at what age would you recommend talking with your doctor about exploring kind of where your fertility is at, and even considering the possibility of, you know, going down the road of preservation?
So definitely fertility is a big topic that I'm very sensitive to. I'm pretty open about the fact that I've gone through a lot of infertility struggles, did IVF and all these things too. So that's something that I have a multitude of years of experience with. So I'm very sensitive to that conversation. And I think that the conversation needs to happen as early as a woman wants to talk about it. I mean, there's women in their 20s that just want to have a conversation, understand what they're looking for in their future. There's things that you can be doing in your 20s that affect your fertility as well. One of those things we talked about was even STD screening, and limit your number of sexual partners, limit your exposure to STDs. Things like gonorrhea and chlamydia can damage your tubes, and those are your fallopian tubes that actually affect your fertility. So there's things that happen in our young teens and 20s and things, and even 30s, that affect your fertility that people don't even ever talk about. And so that's something right in the 20s with screenings we could be talking about that for prevention purposes. We were talking about women and PCOS and talking about their fertility related to that. We can talk about diet, we can talk about their weight, we can talk about insulin resistance. There's a lot of things that encompass that. I'll diagnose women a lot with like PCOS based on irregular menstrual cycles and fitting the criteria for it. And then I'll ask them, okay, what are your fertility goals right now? If they're not planning to get anytime soon, then we say, great, we can treat your PCOS with a birth control pill. We can look for these methods. If they're saying, well, I just really want to get pregnant, then we can treat it in some different ways. We can talk to the OB-GYNs. We can go down the reproductive endocrinology and fertility doctors. There's a whole pathway that we can do to support them. There's not necessarily an age cutoff. I have had patients who get pregnant very, very easily, obviously from like 16 years old, 45. We did have a patient not that long ago who was 45 and, accidentally got pregnant. So it's definitely something that can happen in all these age ranges. So I wouldn't say there's a specific cutoff. A lot of women, once they turn 30, if they're single, they do start to have these conversations a lot more. They may be interested, and I think that's appropriate to have a conversation about what is fertility preservation. If we're talking about egg retrieval, egg banking, things along those lines, what does that look like? Women that have fertility struggles because they are related to a cancer diagnosis or something, that's a different category as well. They have to make sure that they're in good hands for that. So it's a conversation that can start any age you want to start that conversation and continue, just matching on where you are in your life. A lot of times people are asking about, I want to get that blood test done that helps decide if I have enough effect.
AMH.
That's called an AMH, yeah. AMH just has a very limited utility, though. We have to be really careful with that. It changes. It's not the same every time you draw. You could get it drawn every single year for 5 years, but it actually could have some big changes. It is in appropriate context. It can actually give a good amount of information about ovarian reserve, but it's not a death sentence if it's low necessarily. There's some things that can help with egg quality and some things that they can do. Very, very high AMHs can correspond to things like polycystic ovarian syndrome. And so it has to be interpreted in the right way by a reproductive endocrinology and fertility specialist. So if you have questions, you want that AMH, make sure you're getting all that information from the right sources and not just, trying to go find some lab that'll run it for you and trying to interpret yourself.
No, absolutely. No, I really appreciate you explaining that, because I know so many people, there's a lot of confusion sometimes about the AMH, and that's really, really helpful and provides a lot of clarity. One other question that we did have is really kind of what you think today are really in this year in 2023 are the most pressing issues in women's health. What are you finding and your practice and things that we should think about and learn more about, honestly?
I think that definitely mental health has become even bigger the past several years, especially it was there before COVID times, but COVID's definitely the added stressor. Mental health is a huge one. It's also one that doesn't get enough attention and appropriate attention. There's too much stigma about it still. I still have women that come in and they don't want to talk about it. They won't tell me, they say this till the very last minute of the conversation when my hand's on the door and I'm about to walk out. They'll all of a sudden say, wow. And we start this conversation, we go through it and all of a sudden they're telling me they're suicidal at home and they've had all these thoughts. I mean, it can get very deep, very fast. And this happens on at least a weekly basis. I'm having multiple patients that we're dealing with big, hard things, postpartum depression, postpartum anxiety. We're talking about just regular major depressive disorder and generalized anxiety disorder, OCD. There's all sorts of different things. And a lot of times there are suicidal thoughts and things that we really have to come up with a game plan. And people get really like, they don't want to admit to a physician or medical provider that they have those thoughts because they're afraid that, someone's going to lock them up and put them away or take away their kids. I think that's a big one. Everyone gets really scared about that. And what they don't realize is that we can help in so many ways together. We can do these things and get you feeling better, but we have no way to help you if you're not honest and start that conversation. And I'll always try to ask those questions, but it is hard if a patient just doesn't want to share it just yet. And so mental health is one of the biggest things. Still has a stigma. It's getting better, but it's definitely something that we need to continue exploring and expanding our services. For example, one of those things is counseling. A lot of patients are really good at counseling. Like, I just don't want to talk to somebody, tell my problems. I have my girlfriend for, we'll go have a glass of wine. That's great for your girlfriends. You still can go have that glass of wine and have that conversation. But we really need to be with somebody who is trained to be able to retrain your brain so it doesn't go from 0 to 100. When we're worried about an anxiety situation, it'll help it train it so it might go from 0 to 20 miles an hour and then stop, pause, correct, logically think and move it back in so that we just don't feel like we're spinning out of control. Or we have medication that can really help it. The medicines we put you on, if you're doing it correctly and practicing the right way, are not addictive. They're not habit forming. They're not going to change your personality. So there's so many things about mental health that I could talk about for like an hour. And it's something as primary care we do all the time because there's not enough access to psychiatry. And honestly, psychiatry, they're really needed for some of those really big, difficult cases that of bipolar 1 disorder or something else going on, really needs some different kinds of medicines and specialty care. Primary care is where we do most of our mental health treatment.
Wow, that's extremely interesting, and we can have another conversation that'll focus completely on that. That's for sure. But yeah, I know, obviously, like you said, with the pandemic, it has just come out so much more, especially within the millennial population, that people are struggling with these different conditions and different issues, but also that mental health workers, I mean, they're short staffed around the country, the services that can be provided. So, I'm sorry to hear that there are so many people who are struggling that you're seeing, but also very happy to hear that they've come out and share those struggles with you to be able to get help. So, no, definitely something for all of us to continue to learn more about. I'm just going to check the chat one more time just to see if there's anything else. And I don't see any other questions. So I think we have covered everything. I know that we had initially set out to. If there's anything else in terms of key takeaways that you'd like to share before we end this evening, you're welcome to.
It's always a big thing to talk about women's health, and yes, it's there's some things that are different from men, but at the same time, a lot of things are the same. Men have the mental health aspects too, so we've got to make sure we're talking to everybody about these things. But specifically, women do come in and feel like they get dismissed a lot for, like I said at the beginning, the hormones thing quite often, and so. I think it's really a good thing to make sure that we're keeping an open mind when we talk to our physicians and say, okay, what else could it be besides my hormones? What else could be? So, be your own advocate and make sure that you're asking all the questions that you feel like you need to in a visit.
Oh, absolutely. Wonderful advice. Wonderful advice. Well, thank you so much for spending time with us this evening, for sharing your expertise and your experience, Dr. Gray. I really appreciate it. And I know everyone who's watching and will be seeing the recording later will as well. So thank you.
Thank you.
And I just want to remind everyone that the live is going to be posted right after this on our Instagram feed. So if you could not make it and you're seeing now towards the end, we know everybody has busy schedules, so you'll be able to watch it in full and can always message us with questions. And please also check out Dr. Gray's wonderful stories on patient self-advocacy on our site at YMyHealth.com, as well as a new women's health piece that I published earlier today on the site. And if you are not following YMyHealth yet, please do so here on Instagram as well as on Twitter. And for more millennial health and wellness content, you can also subscribe to our monthly newsletter. Thank you again, Dr. Gray. And
bye. Thank you, guys.
Bye. Thank you.